Good afternoon, everyone, and I'd like to welcome you all to the first OC3PR for 2024. I think we'd all recognize that 2023 was a difficult year, but I do believe that things are slowly improving, hopefully getting back to a reasonable normal. When I reflect, though, on doing critical care for more than 20 years, it's become increasingly clear that end-of-life issues are only becoming more complicated, not easier. The impact of policies from our colleges may have compounded some of the difficulties, but the end-of-life process has so many more issues and problems surrounding it that there's not likely to be one perfect solution. That is why today's presentation is relevant, as we will be discussing some of the issues that surround that topic today. As many of you know, Ontario's Critical Care Clinical Practice Rounds, or OC3PR, is the bi-monthly educational series presented by Critical Care Services Ontario. Its mandate being to provide the skills and knowledge to health professionals, be they medical providers or administrators, all of us who help ensure that the care provided to patients is the highest possible standard. All of the previous webinars are available either at the CCSO website or on their YouTube channel. For today's session, you'll have the opportunity again to submit questions or comments via the Zoom chat feature. Just send them to the people named Q&A for question and answer. Today's questions are being fielded by Dr. Bernard Lawless and Ms. Michelle Stevens, both members of the OC3PR Executive Committee. As always, please do your best to keep yourself muted for the presentation. As discussed earlier, end-of-life concerns that we experience in critical care seem to be occurring more frequently and more complex in nature. The adage that just because we could do something does not always mean we should do something. The moral distress experienced by staff in episodes of perceived futile care is not insignificant. To help us better understand some of the issues relevant to this topic, along with an innovative approach to end-of-life care that aims to prevent issues while improving the overall care provided, we are fortunate to have with us today two speakers. Dr. Alison Fox-Robichaud is a professor of medicine and is the Hamilton Health Science Chair for Sepsis Research at McMaster University. She's presently is the head of the critical care response team at the Hamilton General Site and is the director of medical education at Hamilton Health Sciences. She is a past president of the Canadian Critical Care Society and was the chair of the Critical Care Examination Board at the Royal College of Physicians and Surgeons of Canada. Internationally, she's very well respected and is a member of the Global Sepsis Alliance Board, along with being on the advisory board of the International Society for Rapid Response Systems. She sits on the council of the World Federation of Intensive and Critical Care, while also leading a new group of international women physicians in critical care medicine. She has over 140 peer-reviewed publications and has received numerous awards and grants, including being honored nationally for her work in early warning scores to prevent patient deterioration. Presenting with her today is Dr. Michael Hartwick. Dr. Hartwick is presently an associate professor of medicine and holds dual appointments with the Department of Critical Care and also with Palliative Medicine. He is the medical lead for the critical care response team at the Ottawa Hospital. In addition to working as an intensivist and palliative care physician, he's also the regional medical lead for Trillium Gift of Life Network. Our objectives today are, as usual, pretty ambitious. We hope to discuss the current end-of-life policy in Ontario, including the history behind its changes and how it aligns with other provinces. We will then explore an innovative program that provides support to patients, families, and health care providers in creating treatment plans that impact end-of-life issues. Finally, we hope this presentation will help all of us be better able to improve end-of-life care policies at your local hospital, including better defining what the role of critical care should be or not be. All of this, all within an hour. Alison and Mike, thank you so much again for agreeing to do this, and I look forward to your presentation and the discussion afterwards. I believe, Alison, you're going to be starting, and I'll pass it over to you.
Thank you, Dave. So we're going to begin with a land acknowledgement. We acknowledge that the province we call Ontario is the traditional territory of many nations. For many thousands of years, the first people sought to walk gently on this land, offering their assistance to first European travelers and sharing their knowledge for survival in what was at times a harsh climate. We seek a new relationship with the original peoples of this land, one based in honor and deep respect. May we be guided by caring and right action as we transform our personal and institutional relationships with our Indigenous friends and neighbors. Next slide, please. Dave's already gone through the objectives for today, so if we can go to the next slide. Thank you. And next slide, I want to thank Dr. Simon Oskowski. I borrowed heavily from some of his slides. And for Dr. James Downer, I'm not sure James is on today, but James was really instrumental. He's now the current president of the Canadian Critical Care Society, but James was instrumental in leading some of this change at the college. If those of you who haven't read this book, I need to sort of plug one of my mentees and one of our own within the province of Ontario. Blair is really doing this during his critical care training at Stanford, really drilled down into this death dilemma and this triangle between the patient, their wishes, their substitute decision maker or makers, and the healthcare team. And as we come, particularly within critical care, to an increasing use of technology, compounded by the resuscitation glorification that's often seen in the media, and a North America phenomenon where there is a lot of people don't die, but people do die and everyone dies. We often have false hope with respect to resuscitation. And I encourage you to take an opportunity to read this paper. Next slide, please. This is heavy on the language, but straight from the new policy. It really defines resuscitation as a suite of interventions. That is, whether we're doing CPR, artificial ventilation, whether we tube, whether we defibrillate, that provided a cardiac or respiratory arrest in an attempt to restore or maintain cardiac, pulmonary, and circulatory function. You don't need to do all of them at the same time. Next slide, please. So when is resuscitation not a standard of care? We could talk about it in terms of the physiology. Resuscitation, CPR, intubation will not necessarily provide oxygenated blood to the brain and or the heart. A ventilated patient who is death by neurological criteria will not benefit from CPR. When the prognosis of resuscitation will not treat an ongoing progressive or end-state illness or complications. Probably the biggest example we often see is very bad end-stage heart failure and chemotherapy or malignancies resistant to chemotherapy. And then finally, we have to think about the proportionality of that. Resuscitation, as we know, is invasive and may not have benefit, and in fact may be harmful. And we still have an honor to not do harm if at all possible. Next slide, please. And finally, resuscitation is not a treatment for ordinary dying. I highlight this series of articles in the X feed from Catherine Mannix, who was an ethicist in the UK. But even the late Queen realized she was at her end of life, and she can teach us about what end of life is all about when she knows these there. Next slide, please. So why do we have this conundrum? Well, in Ontario, what we have, unlike many other provinces in Canada, is the Healthcare Consent Act. It assumes that most people have the capacity to make decisions about their care, but we also need to consider particularly the hierarchy of the substitute decision maker. That is, who is the substitute decision maker when that person does not have capacity? All treatments require consent. That is both time and context specific. And I apologize for my figure being over some of the words. And then finally, treatment, as per the HCCA, is defined as anything that is done for a therapeutic, preventative, palliative, diagnostic, cosmetic, or other purposes, okay? And this, unfortunately, has underpinned some of the challenges we've had with end-of-life care and our policies over the past few years in terms of both legal actions and policy decisions that have been made as a result of that. Next slide, please. So we're going to go back to 2015. In this policy, and I was coming on to the executive of the Canadian Critical Care Society, and I remember a particular meeting at Critical Care Canada Forum when this came out. And this policy stated that if patient disagrees and insists that CPR must be provided, the physicians were given a must order that we must engage in conflict resolution and we must provide CPR. The challenge with the policy as it was in 2015 is they never consulted the critical care community, and they were quite surprised when the critical care community stood up and said, we have a problem with this. Next slide, please. What were the consequences of this? First of all, the substitute decision makers often ended up compelling us to do CPR, even if there was no physiological rationale. The substitute decision makers might even contravene what we knew or suspected were the patient's prior wishes. And there was no guidance, even with a revision that was done in the interim before this most recent one, on how long to provide CPR, and that resuscitation was more than just chest compressions. Did the policy at the time only apply to chest compressions? And then finally, there was a huge impact on the team between the SDMs, our patients, and the healthcare team. All of this was sort of settled for us in a series of long court battles that I'm not going to report on today for the sake of time, in the Ontario Superior Court of Justice in 2019, issuing a decision which said a no CPR order and withholding CPR does not fall under treatment according to the Healthcare Consent Act. And this is where, but it has still taken us 4 more years in a pandemic to get to this new policy. Next slide, please. So this is the new policy issued and approved in council and issued in March of 2023. It has 4 major parts to it. Advanced care planning and goals of care. There is some must language about that. I'll leave the mic to the discussion about how that might be implemented, but we must do advanced care planning on all teams. I'm going to particularly talk about the last 3, the withdrawing, the withholding, and how to manage disagreements. Next slide, please. So, withdrawing life-sustaining therapy. I haven't cited the Rizzoli case, but it's based on the case of Rizzoli that occurred at Sunnybrook that says, based on a Supreme Court ruling, physicians must obtain consent from patients before withdrawing life-sustaining therapy. We must explain why it's appropriate to withdraw and propose treatment plans during and after withdrawal of life-sustaining therapy. The physicians who may disagree with the family's decision to continue advanced life support could apply to the Consent and Capacity Board for withdrawal of life support if there are disagreements, if they think there's a disagreement between what the patient's wishes are and the substitute decision maker, or if you believe that the substitute decision maker is not acting in accordance with the legislative requirements. That is, they are not listening to what the patient's wishes are. Next slide, please. So withholding resuscitative measures is not treatment and therefore does not require consent. But similarly, we need to weigh the risks and benefits, the harms associated with resuscitation versus the potential benefits. And the new policy clearly states we have to be careful that we're not imparting our own beliefs in that. Next slide, please. So withholding resuscitative measure means that we must consider those patient values. We must, if at all possible, write an order before and inform the patient before writing the order or their substitute decision maker. Say why we believe our diagnosis or their prognosis or what resuscitation is going to do versus the harm, and detail what we're going to do to provide additional care. If we believe the patient is actively dying in front of our eyes and rest is imminent, we can write that order, but we still got to go back and explain to the family at earliest opportunity why we wrote that order. Next slide, please. Disagreements are going to occur. They've always occurred. Families, as we said at the beginning, don't always understand that resuscitation is not like it is on TV. And so we must, at the earliest opportunity, clarify what we've said, identify the basis of disagreement, provide them the emotional support, and reassure them that we're not going to stop caring for that patient, refer them to other providers, and truly seek a second opinion. If you are not sure you're in the right direction, find a friend. And then finally, refer the family to the ethics and the ethics team. Give them the phone number if you're continuing with disagreements about what CPR may or may not provide. Next slide, please. Simon created this figure, and I have to thank him for it because it really does provide a bit of a framework for looking at. It talks about advanced care planning, talks about goals of care discussions, the patient's wishes, and our standards of treatment, and follows down a pathway that says the patient accepts those life-sustaining treatments or declines them, and you write the orders to that effect, respecting those wishes and values. But if they disagree, you can still write the order to withhold CPR, ACLS, write the allow natural death order, but provide the support that's necessary. Next slide, please. Finally, I did a little bit of a search across the country, and it's clear that Ontario's been a bit of an outlier in all of this. The only two provinces who have defined within their physician policy guidelines or other provinces are Saskatchewan and Manitoba. In Saskatchewan, it really says that, similar to what we now have in Ontario, we're not obliged to what they define as futile resuscitation, and that patients and their SDMs cannot demand that. Manitoba clearly says if there is disagreement, you must seek a second opinion. So they put the must language in the second opinion. There is nothing elsewhere across the country. And with that sort of high overview of all of this, I'm going to turn it over to Dr. Hartwick to continue talking about advanced care planning.
Thanks very much, Alison. Thank you, Dave, for the invitation to talk a little bit about what we are doing here in Ottawa to help translate the policy and work with advanced care planning and the guidance we have. So I'm going to tell you a little bit about the Ottawa Hospital Advanced Care Planning Consult team. I'd like to thank my friends and colleagues, Dr. Gianni DeGidio and Kwadwo Karamenteng, as well as our department for helping us plan this and support this and put it together. And move to the next slide there. So we'll go to our third objective, which was how do we integrate this knowledge into end-of-life care policies at our own institutions and discuss specifically the role that critical care might play. In 2022, we were in the same place in Ottawa that I think many people found themselves, trying to do better in terms of advanced care planning, how we communicated with families. We were working in parallel with lots of our colleagues, learning, training our trainees, using things like Serious Illness Conversation Guide, different tools to try to identify patients and families at risk. We investigated the role of critical care response teams, specifically the paper that I have in the upper left corner there, looking at the role of the multi-professional composition of that team and how that lended opinion and support to our colleagues in the hospital dealing with these kinds of cases and sometimes conflicts. We, like everybody else, were coming out of the pandemic that had profoundly changed the way we had an opportunity to communicate with patients and families, introduced issues about resource and moral distress, as Dave has pointed out, all at the same time struggling with some of the shortcomings of the previous policy and where that left us, often arriving quite late in these conversations. We'd had over 5 to 7 years, 16 consent and capacity board cases led by members of our Ottawa Hospital critical care staff. Next slide, please. We imagined that there had to be a better way, that there had to be some way that we could, first and foremost, improve patient care, improve patient and family experience with situations like this, improve our staff satisfaction and engagement, somehow have a process that honored equity, fairness, and transparency, all the same time thinking about something that would be sustainable. Next slide. So early in 2022, what started really as hallway and office conversations coalesced into a framework about how we might offer and establish hospital treatment plans, particularly in situations that we could see might be starting to struggle. We imagined a multi-professional consult team that could see patients and families and the care teams identified by the hospital care teams themselves as situations at risk, support that communication, decision-making, and often conflict resolution. I'll take the next slide. So we brought that to our Medical Advisory Council. Our plan on feasibility was initially to launch that in one of our level 2 step-down units at one hospital campus to see how we could make it work. And we did that in July of 2022 and got a total of, if you just advance the slide there, a total of 0 consults over 6 months. And we'll move ahead one. So we had to go back to the drawing board, and our ideas were that we probably had shortcomings in terms of our design, in terms of our information and how people knew how to reach out to us, our technology, in terms of making it easy for people, what information they needed to prepare, documentation. We went back to work on that. At the same time, we received some, I think, valuable feedback from our colleagues about what things would look like, concerns about our involvement in care of their patients and potential overstep or professional interference, if you might think of it that way. There was questions about, what motivated all of this, and so we had to go back with a broader education and engagement of our colleagues and all the interested parties to talk about what our goals were and why we would do this. At the same time, we had the revision of the CPSO End of Life policy, which was released in March, and our hospital followed quite quickly to revise their own end of life policy in April, so that we were able to go ahead and relaunch in May of 2023. I'll get you to move ahead one slide for me. So on May 10th of 2023, we relaunched, this time going hospital-wide, and I think importantly, hospital resourced. We had put together a true multi-professional team with engagement of our patient relations department, our ethics department, our spiritual care department, as well as hospital legal as a resource to us that could come together on all these cases. We built it into our Epic EMR so that those consults could come directly to us and people knew how to reach us. And we were going to offer the service non-emergently, Monday to Friday, not in evenings, in a way that would be planful and proactive, again, to support, to educate, to provide that second opinion that Alison spoke about, hopefully to provide expert communication and some measure of conflict resolution. I'll get you to advance one. And over the next few months, we received exactly 0 consults, and advance one more. But in the ensuing months since August, we're now up over a dozen consults into the new year, and things are moving ahead with much more success. Move ahead one slide for me. So what is the actual process? What are we providing now? You'll see I've put the patient at the center here. The consult will come to us through our EMR, again on a non-emergency basis, identified by the care team. We have a prompt that has asked them to do some informational work, obviously to have met with the patient and the family to try to identify whether this person has capacity, who their appropriate substitute decision maker is, and as much documentation as possible. And when we receive the consult, there's a chart review process where we'll go back through and gain a lot of that information as well. We try to understand what communication has already happened, what are the understandings that have happened, are there any conflicts, prognosis, history, physiology, all the things that Alison mentioned, and to try to see what opinions we have come to support this already. Do we have the appropriate expert opinions in that person's illness, and what the prognosis might be, so that we can accurately assess the standard of care. We meet the patient and or family in consultation and see all of this stuff face to face, and try to provide then all of the communication that Alison has detailed. What is this person's understanding of the illness or the families? What are these previous expressed wishes and values as they pertain to this situation? Are there ethical and spiritual issues that we can support in the multi-professional ways that we've talked about? We communicate about the prognosis, any limitations, and have now a more standardized form of documentation. And I think hugely importantly, bring all our hospital resources to bear with second opinions, expert opinions, and so that we have a more robust process and the follow-up piece. Next slide, please. If I had to think about what have been keys to success in this, one is the expert opinion, and this is, I think, is an important role for critical care. Many of our colleagues, when having conversations about limiting resuscitation, are seeking advice from people who provide resuscitation and can speak perhaps more clearly about its benefits or lack thereof in these situations. We're providing a means for second opinion for each other. So I think many people have seen the role of critical care response teams in end-of-life care. Those are often late or just-in-time solutions, and we're offering another process to provide second opinion there, and ideally, again, increase equity, fairness, transparency. Lastly, we're providing follow-up, and that follow-up is support. And you saw it flash up there from Renisha. Since starting this, we haven't had any CCB cases that we've been involved in. And I don't mean to suggest that this consult team is the sole reason for that, but I think the combination of the revision in policy and building a structure to support that has helped us. Next slide. What challenges have we faced? Well, the one that has come to the forefront is this is policy, it's not law. And so we've had questions and interpretations about how do we proceed this? How is this going to be handled legislatively? Where are we on this? And there is precedent in Ontario, which we can talk more about, but that's been an issue that has arisen as we've gone along. Representation is an issue. Who is representing the family? Who's representing the hospital? Who's representing the physicians and healthcare providers involved? And so we've tried to do the best we can to harness those resources. As I said, we've had great participation from our hospital legal department, but at times where we think there's risk, we reach out also to the CMPA for our own advice. We have had to navigate issues of access and who's in the circle of care for patients, and try to be quite cautious around the discussions that arise as we sort through this. Certainly early on, when we had no consults, there was no issue around workload, but the workload is increasing with this, and right now there's a pretty small group that is taking this on, some of whom are taking it on as part of their regular job for the hospital, physicians who are taking it on as extra things, and it's often time consuming, and all of these cases are challenging. So I think that we're trying to be mindful of stress and wellness as we all work through some of these really difficult cases as well. I'll go to the last slide. In terms of future directions, I showed you our goals at the beginning. I think we're starting to meet those goals. We're getting, I would say, very positive informal feedback from both our colleagues and patients and families about adding to this process, actually having a a process around it with support and follow-up. And I think a goal going forward for us will be to start measuring some of these things and evaluating whether we're meeting the targets that we set for ourselves almost 2 years ago now. Next slide. With that, I'll conclude. I know we wanted to leave lots of time for discussion, and I have no doubt that'll be the most important part here.
Thank you both. I have a lot of questions, but I will go to Michelle in a minute or two. Alison, when you put up the slide across Canada, it always strikes me that the dilemma of healthcare being provincially run and influenced by the federal government, and maybe in your past role as president of the Canadian Critical Care Society, any idea whether or not some of these issues pertinent to end of life will ever come from the federal government? I know it took a Supreme Court that addressed medical assistance in death for that to be addressed. Any hope for that we'll get guidance or assistance from the federal government, or is that a dream that won't ever come true?
Thanks, Dave. Start with a bang. That's the tough one. You know, the Canada Health Act hinders some of that standard across the country for sure, because a lot of this is politically tied. You know, Manitoba was very instrumental in getting their Vital Statistics Act changed. When James and I approached the previous Deputy Minister of Health to say, listen, we have this problem. Can we do this? There was absolutely no appetite to change some of the challenges we've had around end of life in this province and do that. So we're left with policy right now. I think, and maybe now that James is president of the society and really has some vested interest in this, we as intensivists in the critical care community need to get ourselves at the First Minister's table. We have been, you know, the country's now seen the importance of our profession, right? But maybe it's an opportunity for us to start advocating a little bit more about some standard work across, because yes, we in Ontario have been subjected to legal things. Manitoba's had some as well, and that's a reason for their policy. But, you know, there's a lot of media look at all of this and other provinces starting to think about it. And perspectives on death are different across the country. They're different in the territories where access to healthcare maybe takes a little longer. I grew up in the Maritimes. There's a different perspective on death there than maybe there is in the big cities in Ontario.
That's great. Thanks. I agree. And then you add cultural influences and things as such. It's I don't think there's a simple answer. And so hopefully Dr. Downer will be able to make some inroads on a very challenging topic. I'm going to go to Michelle now to ask some questions, and we'll come back. And I do have several more, unless we have many from our audience.
So thank you very much, Dr. Fox-Robichaud and Dr. Hartwick, for a very interesting discussion. I do have a question from the audience. It's asking to Dr. Hartwick, how might the Ottawa Hospital program be adapted to a busy community hospital setting where there might be less available time to take on such exhaustive consults?
It's a good question. I think that the answer is probably each place is unique, but I would encourage people to build things with all of your professionals, any groups that you see as participant in this, and ideally with the support of your hospital. That was a big change for us. We had the hospital leadership behind us. We had the MAC, our Medical Advisory Council, behind us, and with those resources, we had the hospital dedicated to allowing people like our patient relations department, our ethics department, spiritual care, our legal department to provide us that support. So there is no way to get around the fact that these are in-depth consults. And as we get busier, we're going to have to think about our human resources on that. But having the support network of the whole hospital and those different departments, I think not only strengthens this service, but also lightens that load.
Mike, I'd add that we also need to do a better job perhaps in training our colleagues to have serious illness conversations, right? There's a lot of evidence that if we could convince our colleagues that having those serious illness conversations early might not lead to some of the conflict and the challenges that we get. And I think that's the one thing I like about this new policy. It really does challenge us to start having, not us as intensivists, but the entire physician community to start having serious illness conversations.
Maybe to build on that, obviously Mike and I are colleagues and have had personal experience with this, being called by an emergency room physician who astutely found in the chart that this team had assessed a patient, and before intubating, putting on a ventilator, gave me a call, and we were able to work together and not escalate what would have ultimately been futile care. So there is considerable benefit in this, and it's how to make it more readily apparent to everyone involved. Mike, is I think been one of the challenges. The number of consults is a little bit obviously disappointing. Any idea of how to increase that number? And I think we often can learn from our CCRT, about the triggers for it. Any thoughts on expanding how the team gets involved? And I know we don't want to usurp the primary or the MRP team, but any thoughts on how we can change that to increase access to this? Because I think it does serve a considerable role in addressing a very complex issue.
Yeah, I think there's an informality to it as well, Dave, in so much as in response to the question asker, our goal was never to usurp the role of the primary or service or the most responsible provider and that relationship, but actually to support and encourage it. I think as the policy changed, we were able to offer increased support to our colleagues, and that's already translating into more informal advice. So we knew that our CCRT team had a major role. That's still happening. We're providing second opinions there as they're requested by our colleagues. The fact that some of these consults are occurring, and I think people are finding them beneficial, is awareness in and of itself. I received a message this week from a colleague, knowing that we provided this service, and we were able to have a brief conversation about support, and a full consult wasn't needed. They just needed a little more information and education, and we're more than capable of continuing to care for their patient and that family themselves. And so that number that I show there of 15 or 16 since August are the ones that I can count formally coming through our EMR, and there's probably half as many again that we have provided informally through CCRT and other ways which are not full consults with the same involvement of the whole team and documentation, but likewise supporting our colleagues and patients and families.
Thanks, Mike. I'm going to go to Bernard, Dr. Lawless, for some additional questions and comments.
Great. Thanks, Dave. And really good discussion so far. Very many aspects of this. So appreciate your thoughts on all of these aspects. There is a question coming in from the group that is wondering around the CCRT teams, and who primarily is sometimes having the conversation with a patient or their family from those teams, whether it's the CCRT nurses or the CCRT MDs, or if we have any sort of sense of that. And just in general, I guess the role of either or for being able to hold these conversations with the family. We know that sometimes with the critical care nurses, they have a vast exposure to the patient and the family, and clearly have some opportunities and expertise to be able to have these conversations, but in some places maybe not permitted to. So any thoughts or comments from either Mike or Alison?
Maybe I'll start, Bernard. Thank you. In fact, I sort of met one of these this past week ago. There was just that situation, a patient who probably should have had this on their chart. They should have not. There was a clear wish on the patient's part to die at home, but they were in hospital. Right? And so the RACE team member, a critical care response team RN, said, like, I want to find out where the family's at. They made those calls and then went back to the MRP team and said, hey, we should be having this conversation, right? We should be documenting this on the chart. You know, don't neglect to put the advanced directives on the chart simply because the patient's wishes is this. So I think our RACE team RNs and RTs and other people that are participating on the team have a very valuable role to continue those conversations, because they do build those therapeutic relationships on a consult. And then, you know, circle back, hey, we've done this. Let's have that conversation. Let's get the orders in the right direction, so we're not doing something that the patient doesn't want to them particularly, right? Patient says, I don't want all of this. We should be respecting that and putting it on the chart.
I think I'm happy to add to that as well. And, you know, I direct people to have a look at Dr. Kwong's paper, the one that is on my first or second slide there, when we tried to look at some of those roles. And yes, it's often the physician that is writing that directive, but that there was a very valuable role seen by all the members of the team, bringing different perspectives and different, maybe different styles of communication to that advice and expert opinion. So echo what Alison is saying about that. There's also some interesting things in that paper as those roles change at different times of the day when different staffing of the team. So, you know, for us at a large teaching hospital where the physician member of that team may be a resident at night supported by a staff person, the dynamic can shift. And so that's where I think, you know, having a supporting process in place, because that CCRT consult is often in a bit of a moment of crisis when the team doesn't necessarily know this patient and the family that well, to have a second opinion, to have a supporting process, I think it has been really helpful for us.
I think it's it probably varies a bit from center to center or on the ward to in the unit in terms of the variability with which some of the staff feel the comfort to have that conversation versus the ability or the reign, I guess, or the domain to have that conversation. And it's something probably we're probably underutilizing some of the resource around how that conversation is cultivated with the family to then ultimately come to some of those decisions about what the directions of care will be. And I think it's an important aspect, and that was an important question. One thing that I wonder is, you know, this is a conversation, as Dr. Neilopoulos has alluded to at the beginning, has been ongoing since, you know, all of us have probably been practicing in critical care. And I find sometimes that there's a incongruence perhaps in how even critical care physicians will approach this, and how as a number of us are set up from, you know, a weekly schedule, week about, and how that then opinion can change from week to week, and how that can be confusing for the staff, or how sometimes the issue doesn't get addressed at all. And I wonder, from the perspective of ensuring some not standardization per se, but even, I guess, a standard in terms of that type of approach amongst critical care intensivists, and how we approach that, and how there's a better alignment between providers and how we go ahead with that. And thoughts from either or both of you would be interesting to hear that.
Mike, do you want to tackle that one first?
I could try.
Easy question.
So I've emphasized through the slides and I guess to the point of almost repetition here that I do feel that the process is important. I think it's a great responsibility, and that piece around transparency, fairness, equity is vital. So I fully support the idea of process. We've also had the experience that even within our team, second opinion and diverse views is important. So some of our consultations are, you know, more straightforward, and there seems to be relatively little ambiguity and or conflict. But any that have more of that, we are able to have a discussion group with input from all these hospital providers that I mentioned, and we have sought our colleagues as a second opinion. And actually, that diversity, if you have trust amongst your colleagues that you're going to get a valid second opinion, it just gives strength to the process. To have to know that the person you ask may potentially disagree with you, and that there is not a formula, necessarily a direct formula to say that every consult that meets this pattern will be seen the same way. So I think having a lens of diversity there is really important to the process, and I would encourage people who adopt this to build that in somehow.
Yeah, I would also say that, you know, Michael, you guys are very fortunate in Ottawa to have 3 or 4 people who are either dually trained or really have an interest in palliative care and critical care. I'm not so fortunate in Hamilton to have that. And you talked about the burnout even in your advanced care planning team and the potential for that. But I would say that those of us who are heavily involved in this and often given that duty, it's look who's coming on this service, they can have that difficult conversation with the family. We really do need the support of our colleagues to say, like, okay, yeah, you've given me those difficult conversations this week, but like, let's go down that journey. What have you talked to them about? You know, have you given them an opinion along the way, or just left it for, you know, those of us who seem to get all of the difficult conversations to have it that week? And so I think we need to share the burden a little bit. We are all burnt out post-COVID. There's no doubt about that. So let's share some of this ongoing burden of around end of life and seek each other colleagues out. Absolutely.
I think that's a good point that you make, sort of, and it's not sort of, it's a good point. And where individuals almost have that sort of sense of like, and the staff have that sense of like, if somebody's new is coming on for the next week, the sweeper's coming in, they'll take care of this, this, and this, or, you know, those sorts of things, or those kinds of comments. And it's not necessarily the connotation, I think, of how we need to be seen, but we need to be seen each as looking after all those components of the patient care, and participating in a meaningful way and having those discussions. So thanks for those answers, and I'll hand it back to Dave.
Thanks. I do notice no one took on the crux of the question of making it a standard. It would be very difficult, but it's one of those necessities, because no one likes having to always be the one to do that. And so how we approach that, I think, is something that is important for all of us to go forward. I'm going to go back.
I'll tackle that, Dave. Just one. So
Okay.
There is a really good paper that just came out. One of Randy Curtis's last papers. It was published in JAMA. I was looking at the date here. Published in JAMA in May. And what Randy and his team did, and they had been working on this in Seattle for a long time, is they looked at those chronic illnesses and they automated in our, you know, a lot of us are electronic across the province now. They automated a little bit of a tease, not to the intensivist, but to the MRP team to say, hey, your patient meets these criteria. here's one of three things you should be having: a serious illness conversation. You haven't got a goals of care on the chart. Maybe you should do that, and just use that as a little push. Like, I know many of us are tired about best practice alerts. They're a bit on the crazy side, but maybe that little bit of poke to the family, to the MRP team, to say, hey, have you had this conversation? These are the chronic things going on with your patient, or this is what's deteriorating with your patient. So there is evidence out there to suggest it has benefit in a standardized approach using our EHS to do it.
Well, that's where I was trying to tweak Mike there, in terms of not just physician asking for help. Is there some other things? And so maybe we can review that paper, Mike, at one of the journal clubs and see whether or not there is interest in exploring it. I'm going to go to Michelle now for a final question, if she has one, and then I'm seeing we're coming close to the end, but I think we have time for about one or two more questions.
I do have another question from the audience, and it's wondering how centers that have automated palliative care consultation are finding this, and if it's scalable.
I wonder, Mike, with being palliative care, with that, it actually builds on just what we were just talking about.
Yeah, so we don't have automated palliative care consultation, so I can't answer well the question of how we're finding that. I think that there is a role for reminders, however they're built in, whether they are generated in a human way from lots of the different professionals in somebody's care to flag it, and empowering people to do that, whether they're automated things, best practice alerts, or whatever we want to call them, to remember to have these conversations. I think all of those things help upstream and probably minimize the necessity for the intervention that I discussed. You still ultimately have to have that process, and so having some expertise built around the process to advise, to support your colleagues through that, to teach, I think is great if you can build that, and you have to purpose build it for your center with the resources that you have. Alison mentioned we're lucky enough in Ottawa to have had a bunch of people who have taken a specific interest in this, who've sought out training in this, and have can integrate it into some of the things that we do, but that may not be the reality. It may be more consultative, and you have to pull from the resources that you have. I think that when we have the more challenging cases, that there is merit to structure that people can see, to know that there is a process that for them to be heard, for things to be considered, for second opinions to be there, to try to ensure that there's equity and fairness and diversity in that system. So that's important. But yeah, the automated stuff I think is useful. And I don't know if I answered that question or went back to what I'm trying to promote, but.
No, I think it's a difficult question to ask. I mean, we often wonder as well, is there any role for the virtual care programs that are out there to get assistance, whether or not, how could you do this as an outpatient? I think sometimes we leave it too much to the end. I think, as Alison said, it's to get our how do we help our colleagues and other professionals to be able to have those so important discussions. And let's be honest, they're better conducted outside of the emergency hospital, imminent problem, and that it can be done in a better pace and a less pressure type of format. So I think that's something we'd all be advocating. And I see in the chat, Alison, you've put the link to that. I would also highlight to our audience, if they can take the time to do the survey. It does help us improve the presentations and come up with future ideas and ways to amend it. So I'm going to say thank you to Mike and Alison, and thank you for this. I think it's the first of many discussions on this and building on a very important topic. And I'm going to go to Dr. Lawless for some final thoughts and closing comments. So thank you both for doing this.
Great. Thanks, Dave. And thank you again for your tremendous hosting abilities and steering our session today. So thank you for that. And thank you especially to Dr. Fox-Robichaud and Dr. Hartwick for your time today, but also bringing together some very key messages and valuable points that we need to be having out there amongst providers around this topic, because I suspect even with some of the changes from the CPSO and the policy piece that make it a bit more or less, I guess, sort of restrictive in having the conversations and the directions that go from that, is that we still need to have conversations about this and conversations about how can this be happening better so that patients have a better experience. And as Dave mentioned and as Alison has mentioned, it can be happening across a broader group of providers than just critical care. And I think we need to be able to have people have that, whether it's permission, whether it's knowledge, whether it's training, whether it's comfort in terms of having that discussion. I think we've all had the experience of somebody with being consulted on CCRT with someone with an end-stage X disease, and everybody agreeing that they wouldn't do well with life-supporting interventions, but still having an active sort of goals or active treatment directives on their chart. And so lots of avenues, I think, to explore this conversation. And thank you both for helping to get some of the message out there and some of the learning out there and some of the updated policy pieces. And we hope that I thank you as well to the rest of the people who've joined as participants to be engaged and to hear the discussion and participate with your questions. So thank you very much, everybody, and have a good afternoon.